Welcome back to the Deep Dive. Today we're jumping into a set of conditions that, might seem common on the surface: urinary bladder pathology. But the clinical reality, and especially the modern guidelines around management, are just incredibly nuanced. We're really going to try and move beyond the basic textbook stuff here.
That's exactly right. The bladder is sort of a complex crossroads, isn't it? You have mechanics, infection, oncology, all meeting in one place. The material we're looking at today covers 6 core conditions that you'll definitely encounter. We're talking benign tumors, bladder stones, trauma, all the different types of cystitis, even TB cystitis, and bladder diverticula.
And our mission today is to equip you, the listener, with those key diagnostic triggers, the red flags you just can't ignore. We're drawing on up-to-date international guidelines here, specifically from big players like the EAU and the AUA. It's all about knowing what to do next, protocol-driven.
Exactly. It's not just about knowing the symptoms, it's about understanding why the guidelines are structured the way they are. I mean, whether it's pushing back against antibiotic resistance or getting cancer staging right from the very first biopsy.
Okay, let's start with what seems like a tricky area, so-called benign tumors of the bladder. The sources all agree. Most of these come from the urothelium, that lining of the bladder. You hear terms like papilloma, leiomyoma, hemangioma. But the immediate warning is that these are actually pretty rare compared to the malignant ones.
And that is the absolute foundation of modern uro-oncology. The rule is simple. Any new growth you see in the bladder is cancer until proven otherwise. You might stumble upon a genuine leiomyoma, but the way it presents is, well, it's identical to the most common bladder cancer, urothelial carcinoma.
So what's that universal red flag we should all be looking for? The one symptom that gets the ball rolling.
It is the single most important one in the entire urinary tract. Painless hematuria, blood in the urine with absolutely no pain, no burning, nothing else. That's the alarm bell.
No other symptoms necessarily.
Well, occasionally, if the mass is really big or it's right near the bladder neck, you might get some difficulty urinating, some obstructive symptoms, but hematuria is the big one. It demands an immediate workup.
So if that red flag is raised, what's the non-negotiable first step?
Cystoscopy. It is the gold standard. You have to look inside the bladder, and more importantly, you have to get a tissue biopsy. You need that tissue to rule out malignancy.
And this is where the terminology has really changed, isn't it? This is what can trip people up if they're relying on older definitions.
Oh, absolutely. The old way of thinking was frankly dangerous. What might have been called a simple, benign papilloma 20 years ago is now managed very differently. It's often categorized under the umbrella of non-muscle invasive bladder cancer, or NMIBC. The key term you need to know now is PUNLMP.
PUNLMP. That's papillary urothelial neoplasm of low malignant potential. That name itself is interesting. It defines the lesion by its risk low malignant potential. It's not saying it's harmless.
Precisely. We consider it part of that low-grade NMIBC spectrum. It's the lowest rung on the ladder, but it's still on the ladder. And because it can, and often does, recur, the management has to be protocol-driven. It can't be casual.
So given that, what does the modern guideline-based treatment look like for one of these lesions?
The primary procedure is the transurethral resection of tumor, or TURBT. It's both diagnostic, it gets you the tissue, and therapeutic as it removes the growth.
But the guidelines are very specific about the quality of this procedure.
They are. The TURBT has to be complete. And the specimen you send to the pathologist must, and I mean must, include detrusor muscle. This is a critical point.
Why is that muscle so important? If the tumor looks superficial, why do you need to go deeper?
Because it's the only way to accurately stage the tumor. If the pathologist finds tumor cells invading that muscle, the stage immediately jumps to T2 or higher. That changes everything. It means radical treatment, like removing the bladder.
And if the muscle isn't there?
If the muscle isn't in the specimen, the resection is inadequate. It's incomplete. You cannot exclude muscle invasion. And that means you run a huge risk of undertreating a potentially lethal cancer.
Wow. So an inadequate TURBT could mean a patient is walking around with an aggressive cancer without anyone knowing. I also understand that sometimes a second TURBT is required.
Exactly. For any high-risk lesion, like a T1 tumor where it's in the lamina propria but not the muscle, or if that first resection didn't get muscle, guidelines mandate a repeat TURBT. You go back in, usually within 2 to 6 weeks, to make sure the staging is right and you've cleared all the tumor. It's a cornerstone of good NMIBC management.
That's a serious level of rigor.
Yeah.
Okay, let's talk about after the surgery. There's this single early dose of intravesical chemotherapy. What's the thinking there?
This is a really effective low-risk intervention. Both the EAU and AUA endorse it. Within 24 hours of the TURBT, you instill a single dose of chemotherapy, usually mitomycin C or gemcitabine, right into the bladder.
And what does that do?
Two things. First, it kills any tumor cells that might have been knocked loose during the resection and are now floating in the urine. You don't want them reimplanting somewhere else. Second, it targets any tiny invisible bits of residual tumor. This one dose can significantly cut the risk of the tumor coming back, especially for these low-risk papillary types.
Since we've established these are not truly benign, what does the long-term surveillance look like? It's not a one-and-done thing.
Absolutely not. The surveillance is rigorous, and it's all risk stratified. For those low-risk lesions, a small single PUNLMP, for instance, you'll do a follow-up cystoscopy at 3 months.
And if that's clear.
If that's clear, you can stretch it out to once a year for several years. But on the other hand, if you have intermediate or high-risk disease, the surveillance is much, much tighter. We're talking cystoscopy every 3 months for 2 years, then every 6 months. You're basically putting the patient into a high surveillance program for life. The takeaway is any growth starts a lifelong follow-up plan.
All right, let's move from tissue pathology to mineral pathology, vesicle calculus or bladder stones. Let's start with that classic patient story.
The patient comes in with a very specific, often dramatic story. They'll say, "Doc, I get this severe pain right at the end of urinating, and sometimes the stream just cuts off, and I've seen blood, but only at the very end."
That sudden stop and the terminal bleeding, that's the telltale sign.
It's highly suggestive of a stone that's moving around and acting like a ball valve at the bladder outlet.
And what's the fundamental reason these stones form in the first place?
It's almost always about urinary stasis. And stasis is caused by bladder outlet obstruction, BU. In adult men, the #1 cause by a huge margin is benign prostatic hyperplasia, BPH.
The enlarged prostate.
Right, the bladder can't empty completely. You get this pool of residual urine that just sits there. It's stagnant, it's concentrated, and it's the perfect environment for crystals to form and grow into stones.
So finding a bladder stone isn't the end of the diagnosis, it's really the start of a hunt for the obstruction.
100%. The clinical rule is a bladder stone means obstruction, plus maybe infection, until you've proven otherwise. Of course, there are other causes of stasis, a neurogenic bladder from a spinal cord injury, for example, or even foreign bodies, like an old suture or a piece of a catheter that can act as a nucleus for a stone to grow on.
You mentioned infection. How does that play into the type of stone we see?
It's critical. Chronic UTIs, especially with certain bacteria like Proteus mirabilis, these are what we call urea-splitting organisms. They produce an enzyme, urease, that makes the urine very alkaline. And in that alkaline environment, you get struvite stones, magnesium ammonium phosphate. These things can grow incredibly fast and get absolutely massive.
Let's quickly run through that diagnostic triad of symptoms again.
Sure. #1, painful voiding or dysuria.
Oh.
2, terminal hematuria, blood just at the end. And 3, interruption of the urinary stream, that sudden positional stop and flow as the stone blocks the outlet.
And there's that classic pediatric exam question about how kids present.
Right. In children, especially in areas where these were endemic, you'd see them adopt these funny positions, squatting or lying prone to try and relieve the pain. They're trying to shift the stone away from the sensitive bladder neck.
So once you suspect a stone, what's the workup?
Imaging is king. First line is often an ultrasound. It's great for seeing stones in the bladder, and it can also measure your post-void residual volume, which tells you how bad the obstruction is, plus no radiation, so it's perfect for kids.
What about other imaging?
An X-ray of the kidneys, ureters, and bladder can see radio-opaque stones, like calcium ones. But cystoscopy is really essential. It lets you see the stone directly, see how many there are, and plan the removal.
But the modern guidelines insist you have to dig deeper than just finding the stone.
This is the most crucial part of management. You have to investigate the root cause. Functionally, that means things like uroflowmetry to measure the stream and post-void residual checks. Metabolically, you need to analyze the stone, check urine pH, get a culture.
And for recurrent stones?
For recurrent stones, you need a full metabolic workup. Blood tests, a 24-hour urine collection. If you don't figure out why the stone formed, you are basically guaranteeing it's going to come back.
So how do we actually get the stone out?
In most cases today, the first-line method is transurethral cystolithotripsy. It's an endoscopic procedure. We go in through the urethra with a scope, break the stone into tiny pieces, and wash them out.
And what do you use to break it up? A laser.
A holmium laser is probably the most common tool now. It's incredibly versatile. It can break up almost any kind of stone into dust. but you can also use pneumatic or ultrasonic devices.
Are there situations where you can't go through the urethra?
Yes. If the stone is just enormous, say bigger than 5 centimeters, or if the patient has a very narrow urethra. In those cases, we might do a percutaneous cystolithotripsy. We make a small incision just above the pubic bone directly into the bladder.
And open surgery?
Open surgery, a cystolithotomy, is pretty rare now. It's reserved for the most complex cases, or if you're already doing another open surgery like an open prostatectomy at the same time.
Now, you stress that the EAU guidance says you must treat the underlying obstruction at the same time.
You have to, because the stone is just a symptom. If you have a patient with BPH and you just take out the stone but leave the obstructing prostate, what's going to happen?
A new stone will form.
Exactly, and probably pretty quickly. So the guidance is clear. You do the stone removal and the therapy for the prostate in the same operation whenever you can. It's holistic management.
And just briefly, that global health context about nutrition and primary bladder stones is fascinating.
It is. It's mostly about endemic stones in malnourished children. They're often related to low protein and fluid intake. And the solution isn't surgery. It's systemic better hydration, better nutrition. It shows how systemic issues can cause very localized bladder problems. Okay, let's switch gears to something more acute. Bladder trauma. This is a high acuity, low frequency event. The bladder is, thankfully, pretty well protected down in the pelvis, so when an injury does happen, it's usually from massive force. Think high-speed car accidents with severe pelvic fractures.
And the classification of the rupture is everything for management, right? What are the two main types?
The location of the tear dictates everything. The most common is an extraperitoneal rupture. This is about 80 to 85% of cases. It's almost always from a sharp piece of a fractured pelvis tearing the lower part of the bladder.
So the urine leaks, but it's contained.
Right. It leaks into the space outside the peritoneum, usually staying within the pelvic tissues.
And the second, more dangerous type.
That's the intraperitoneal rupture. This happens when the dome, the very top of the bladder, tears. This part is covered by the peritoneum. It usually happens when a full bladder gets a direct, sharp blow, like from a steering wheel. In this case, urine pours directly into the abdominal cavity. This causes peritonitis, severe pain, and it's a surgical emergency.
In a chaotic trauma bay, what are the immediate clinical clues that should make you suspect a bladder rupture?
You're looking for suprapubic tenderness, an inability to pass urine, and gross hematuria, visible blood in the urine. But there is one sign that changes your entire sequence of actions.
And that is?
Blood at the urethral meatus. If you see blood at the tip of the penis, that's a hard stop.
Okay, this brings us to that critical trauma warning. The one mistake you can't afford to make.
The warning is this: never pass a catheter blindly if you suspect a urethral injury. Blood at the meatus in a pelvic fracture patient means you have to assume the urethra is torn until proven otherwise.
And if you push a catheter through that tear,
You risk turning a partial tear into a complete transection. You can cause irreversible damage, leading to lifelong stricture disease. It's a devastating complication from a preventable error.
so if you see blood at the meatus, what's the mandatory next step before any catheter goes in?
You must perform a retrograde urethrogram, a RUG. You gently inject contrast dye into the urethra under X-ray to see if it's intact. Only if the RUG is negative can you safely proceed with catheterization.
Assuming the urethra is okay, what's the gold standard for actually confirming the bladder rupture itself?
CT cystography. Modern guidelines mandate it for any patient with a pelvic fracture and gross hematuria. You fill the bladder with contrast through the catheter, clamp it, and then do the CT scan. It's much better than old plain X-rays.
So let's talk management. How do you treat an uncomplicated extraperitoneal rupture?
Catheter drainage alone, that's usually all it takes. The urine leak is contained, so you just decompress the bladder with a Foley catheter for about 10 to 14 days, and it heals on its own. We'll do a follow-up cystogram to confirm it's healed before we take the catheter out.
And what makes it a complicated rupture that needs surgery?
Well, any intraperitoneal rupture always needs surgery, but an extraperitoneal one becomes complicated if you see bone fragments inside the bladder, if the injury involves the bladder neck, which controls continence, or if there's an associated injury to the rectum or vagina. Any of those means you have to operate. The repair involves a 2-layer closure of the bladder wall to get a really good watertight seal, and then you still keep it drained with a catheter while it heals. The classification truly dictates the entire plan.
Let's move on to cystitis, inflammation of the bladder. This is something we see every day. The symptoms are familiar to everyone. The burning, the urgency, the frequency. But the key here is differentiating between a true infection and a purely inflammatory problem.
Exactly. The baseline is acute cystitis. That's your common UTI. Usually bacterial E. coli is the villain in most cases. You get a positive urine culture, and it clears up with a short course of antibiotics. But chronic cystitis implies something more is going on, recurrent infections. If a patient keeps getting UTIs, you have to hunt for an underlying cause stones, poor emptying from an obstruction, something that's acting as a persistent bacterial hideout.
Then you have the non-infectious syndromes. Let's start with hemorrhagic cystitis.
Hemorrhagic cystitis is acute inflammation with a lot of bleeding. The classic cause is chemical from chemotherapy drugs like cyclophosphamide. They produce a toxic metabolite, acrolein, that just shreds the bladder lining.
You can also be viral, right?
Yes, in immunocompromised patients, you can see it with viruses like adenovirus. Management is really about hydration and sometimes bladder washouts to control the bleeding.
Okay, and now for the one that really mimics chronic infection. Interstitial cystitis, also called painful bladder syndrome.
This is a really tough diagnosis. It's a diagnosis of exclusion. These patients have all the symptoms: chronic pelvic pain, frequency, urgency, but their urine cultures are always negative.
So what's the clinical pearl? What's the key thing that distinguishes it from a bacterial infection?
It's the specific pattern of the pain. The pain gets worse as the bladder fills with urine, and then, this is the key, it is characteristically relieved upon voiding.
That relief is the crucial factor, and what's actually going on in the bladder wall.
It's complex, but it seems to be a defect in the protective lining of the bladder, the JEG layer. This lets irritating substances in the urine seep through and inflame the underlying muscle and nerves. On cystoscopy, you might see these tiny pinpoint hemorrhages, or in more severe cases, specific lesions called Hunter's ulcers. It's a chronic condition managed with lifestyle changes and various therapies, not antibiotics.
This whole discussion of infection brings us right to the biggest challenge we face today: antibiotic resistance. The 2024 EAUAUA guidelines represent a major strategic shift.
It's a massive change in practice and a necessary one. For simple, uncomplicated cystitis in women, the focus is now entirely on minimizing collateral damage and fighting resistance.
So which antibiotics are now considered first line, and why the emphasis on short courses?
We want drugs that concentrate highly in the urine but have a narrow spectrum, so the first-line agents are recommended for the shortest possible duration. You're looking at fosfomycin, which is a single 3-gram dose.
Just one dose?
One dose. It's incredibly convenient. Or nitrofurantoin for 5 days, or another one called pivmecillinam for 3 to 5 days. Short courses are just as effective, and they dramatically reduce the pressure for resistance to develop.
And what's the flip side of that? Which antibiotics are we now told to avoid for simple cystitis?
The guidelines give a strong instruction to avoid aminopenicillins like amoxicillin because E. coli resistance is just sky high. And even more critically, we must reserve the fluoroquinolones drugs like ciprofloxacin.
Why the focus on Cipro?
Because we overuse them for simple UTIs for years, and that has driven resistance in much more serious infections, and they also carry a risk of serious side effects. We have to protect these drugs for when we really need them.
This leads us to another area where we used to overtreat: asymptomatic bacteria, or ABU.
ABU is basically colonization. You have bacteria in the urine, but no symptoms. The guidelines could not be clearer on this. Do not screen for or treat ABU in most adults who aren't pregnant.
Why not? It seems counterintuitive.
Because treating it doesn't help the patient, and it does cause harm. It just selects for more resistant bacteria and increases the risk of other infections like C. diff.
But there are two very specific exceptions where we must treat it.
Only two. First, in pregnant women, because ABU increases the risk of kidney infections and preterm labor. Second, in patients who are about to undergo an invasive urological procedure where you expect bleeding, like a TURBTT. Outside of those two situations, we leave it alone.
And finally, what about preventing recurrent cystitis without using constant antibiotics?
The trend is moving away from continuous low-dose antibiotics. For postmenopausal women, localized vaginal estrogen is very effective. It restores the healthy vaginal environment. For non-hormonal options, methenamine hippurate is strongly endorsed.
How does that one work?
It's quite clever. Methenamine is a prodrug. In acidic urine, it breaks down into formaldehyde, which is a non-specific antiseptic that sterilizes the urine. Because it's not a traditional antibiotic, it doesn't generate resistance. It's an excellent prophylactic option, alongside things like good hydration and timed voiding.
Now we have to talk about a very specific and severe form of inflammation: Tuberculous cystitis.
Right. When tuberculosis gets into the urinary tract, usually spreading down from the kidneys, it sets up this chronic, slow, but incredibly destructive granulomatous inflammation.
This leads to the classic feature, the thimble bladder. What does that mean?
It means the chronic inflammation causes so much dense sparring and fibrosis that the bladder wall becomes rigid and non-compliant. It physically shrinks, losing all its capacity. It becomes a small, thick-walled, contracted pouch like a thimble.
And the symptoms must be extreme because of that tiny capacity.
Crippling. Patients have severe frequency, they're up all night, intense pain. The bladder might only hold 100 milliliters or even less, and the fibrosis can also creep up the ureters, causing blockage and kidney damage.
What's the single biggest diagnostic clue that should make you think of GUTB, especially if it just looks like a chronic UTI that won't go away?
The key is sterile pyuria. You do a urinalysis and you see lots of white blood cells. That's the pyuria, the inflammation. But then the standard urine culture comes back negative.
No common bacteria.
Exactly. So if you have a patient with severe urinary symptoms, they aren't responding to normal antibiotics, and they have sterile pyuria, you have to start a TB workup. High frequency, low capacity, sterile pyuria, that's the triad.
So how do you actually diagnose it?
It requires specialized microbiology. You need to collect multiple early morning urine samples, at least 3, sometimes up to 6. You send those for an AFB smear, for specialized TB culture, and now, critically, for rapid molecular testing.
You mean tests like expert MTBRF? Why are they so important?
For 2 reasons. Speed and resistance detection. A culture can take weeks. The expert test can confirm TB DNA in a couple of hours. And crucially, it also tells you if the TB is resistant to rifampicin, which is one of our most important drugs.
So that immediately changes the treatment plan.
Immediately. It tells you whether you can use the standard first-line regimen or if you need to move straight to a regimen for drug-resistant TB.
For drug-susceptible GUTB, is the treatment the same as for TB in the lungs?
Yes, it's the standard 6-month regimen of HRZE for 2 months, followed by HR for 4 months.
And if it is resistant?
If it's drug-resistant, you have to use a specialized DRTB regimen. The good news is we're moving away from the old toxic injectable drugs to newer all-oral shorter regimens like Bpal-M. They are much safer and more effective.
The final key point is the timing of any surgery. The bladder is severely damaged.
Yes, but you can't operate right away. The guidelines are emphatic. Any major reconstructive surgery, like using a piece of bowel to make the bladder bigger, is only done after the patient has had adequate antitubercular therapy. You have to get the infection under control first, or the surgery is likely to fail. Okay, our final topic is another structural problem, the bladder diverticulum. This is basically a pouch or a sac that protrudes from the bladder wall.
A little outpouching. And there are different types, right?
2 main types. Congenital ones are rare, you're born with them. Much more common are acquired diverticula, and these are, again, the result of chronic high-pressure voiding.
So it's that same theme again, bladder outlet obstruction.
Exactly. BPH, urethral strictures. The high pressure inside the bladder forces the inner mucosal lining to herniate out through weak spots in the detrusor muscle.
Why is this pouch such a problem? It seems simple enough.
Because it creates a triad of problems. First, because it doesn't have a good muscle layer, it can't empty properly. That leads to urinary stasis. Second, that stasis is a perfect breeding ground for chronic infections and for stones to form inside the diverticulum.
What's the third and most critical risk?
The risk of carcinoma. This is the key insight. The wall of an acquired diverticulum is very thin. It lacks that protective muscle layer. So you have an environment of chronic inflammation from the stasis and no muscle barrier. It's a high-risk site for cancer to develop. And if a tumor starts growing in there, it's essentially pre-staged at T2 or higher because it's already through the muscle layer that isn't there.
That's a huge point.
Yeah.
So how do you diagnose one?
A cystoscopy lets you look inside and see the opening or neck of the diverticulum. And imaging, like a contrast CT scan or an old school MCU, can show you the size and shape of the pouch and how well it empties.
Is surgery to remove it, a diverticulectomy, always required?
No, and that's the nuance in management. If you find a small asymptomatic diverticulum, and especially if you can treat the underlying outlet obstruction, you can often just manage it conservatively with monitoring.
So when does it become non-negotiable? When do you have to operate?
The hard indications for surgery are recurrent infections that you just can't clear, stones or a proven tumor inside the pouch, or if the diverticulum itself is so large that it's causing an obstruction.
And the surgical options today are mostly minimally invasive.
For larger ones, yes. Laparoscopic or robotic diverticulectomy is now very common. open surgery is rare. For some smaller ones in high-risk patients, you might consider an endoscopic approach to just widen the neck. But the absolute surgical principle, just like with bladder stones, is you must relieve the underlying outlet obstruction. If you just remove the diverticulum but leave the high pressure from the BPH, the bladder will just form another one. So, to pull all of this together, let's do a rapid-fire revision of the highest yield clinical indicators, the one-liners you really need to remember.
Okay, let's do it. Diagnosis and danger signs.
Benign bladder tumors, painless hematuria. Always think non-muscle invasive bladder cancer, and your TurboBT specimen has to have detrusor muscle.
Vesical calculus, bladder stones, terminal hematuria, and an interrupted stream. And you absolutely must find and treat the underlying outlet obstruction.
Tuberculous cystitis, severe frequency, that small contracted thimble bladder, and the definitive clue of sterile pyuria.
And for acute cystitis.
Remember the new antibiotic rules. Short course fosfomycin or nitrofurantoin, and you must reserve your fluoroquinolones.
Bladder diverticulum.
Think urinary stasis, chronic infection, and that high-risk warning that a tumor inside is treated as potentially invasive.
Okay, so let's just hammer home those crucial safety rules from the guidelines one more time.
With bladder stones, it's simple. Obstruction is the cause. You have to treat the BO at the same time as you remove the stone.
In trauma, the single biggest mistake a clinician can make.
Never, ever catheterize blindly if you see blood at the menis with a pelvic fracture. You must get a retrograde urethrogram first.
And for any growth you see in the bladder, no matter how small.
That patient is now in a cancer surveillance program for life. It's all about quality resection and a risk-stratified follow-up schedule.
And finally, that huge strategic shift in managing UTIs.
It's a decisive move away from broad-spectrum antibiotics. Use short courses, don't treat asymptomatic bacteriuria, and use non-antibiotic options for prevention whenever you can.
You know, you connect all these dots, the one thing that really stands out is this common thread of chronic stasis and chronic inflammation. It seems to be the engine driving almost everything we've talked about, from stones to diverticula to TB, this long-term simmering inflammatory state.
And that raises a really important question for you to think about later on your own. If stasis and inflammation are the shared factors that accelerate the risk of stones, scarring, and even cancer, how much of this localized bladder disease is actually a sign of a systemic issue? And, more importantly, how does knowing about this common inflammatory pathway change how we should think about long-term cancer screening for these patients? Understanding that inflammation might just be the next frontier in preventing a lot of this pathology in the first place.
A really compelling thought to end on. It highlights just how critical that lifelong surveillance is for these complex patients. Thank you for joining us for this deep dive.
Thank you.